ஐந்து கரத்தனை ஆனை முகத்தனை இந்தின் இளம் பிறை போலும் எயிற்றனை நந்தி மகந்தனை ஞான கொழுந்தினை உந்தியில் வைத்தடி ஊற்றுகின்றானே. ஓம் நம சிவாய. Hi everyone, let's start the session with prayer, and with this we're going to start this session. My name is Dr. Tilakar Kannapan. I'm the Vice President for NPNA. We're going to have a beautiful session today with our awesome speakers. We have three great topics on sudden cardiac arrest, attention deficit disorder, anxiety and depression, and also on navigating the insurance plans after retirement. So, the NPNA has been there since 2018, and we are giving the opportunity to conduct at the outset, I want to thank NPNA, especially Dr. Mr. Parni Parniappan, for giving us the opportunity to do the medical symposium in NPNA. Noi Nadi, Noi Mudal Nadi, Adu Thanikum, Vai Nadi, Vai Pachai. The purpose and goal of this symposium is to share the knowledge and update the current standards in the medical practice in USA to our fellow physicians, and educate and share our knowledge with our fellow non-physician Nagartha and Nagartha Health Club members. Today, we have some amazing topics, current healthcare concerns to be discussed by our amazing panel of doctors on sudden cardiac death, ADHD, anxiety and depression, and navigating the health insurance after retirement, followed by open medical forum to announce all of your questions. NPNA was founded and inaugurated in September of 2018. Since then, we have been marching forward, adding new services. Now we'll play a video updating the NPA's activities.
One more time.
The small video to be played.
It's showing up here, but it's not showing there.
Why don't you play the video?
One moment.
I was trying to play this. While we're waiting for the video, let me introduce Dr. Mutharagu. I have the pleasure of introducing Dr. Mutharagu, our CME chairman for NPNA. She'll be coordinating this medical symposium, and she will introduce the speakers. She is a hematology oncology doctor. She's a cancer specialist, and she did her MBBS in Tamil Nadu MGR Medical University on Government Kilpauk Medical College, Chennai. From 1991 to 1997, she did her postdoctoral training and residency in Boston University, Roger Williams Medical Center, Providence, Rhode Island. Subsequently, she did her fellowship in hematology oncology, hematology branch of National Heart, Lung, and Blood Institute, National Institute of Health, Bethesda, Maryland. 2006 to 2009, she's had academic appointments. She's a professor of medicine, Department of Medicine, Division of Hem-Onc, and stem cell transplantation in University of Massachusetts, Worcester, Massachusetts. Honors and awards, she's completed her UMass Physician Leadership Program, ASBMT Inaugural Leadership Course, and she's had Sarah Stone Excellence in Education Award, Hematology Oncology Fellowship Certification of Appreciation for offering flexible clinical experience course for UMass medical students. Introduction to Hematologic Malignancy. Without further ado, I'm going to turn the mic over to Dr. Mutharaga. We'll play the video a little later. It's on?
Yeah, it's not.
Okay, that's fine. Let's do the play. Thank you.
அனைவருக்கும் காலை வணக்கம். Welcome everyone to the NSNA NPNA Health and Medical Symposium. We are very excited. Thank you very much to Michigan Detroit NSNA team for giving us this opportunity. We have excellent speakers, excellent topics, and a medical forum. I hope all of you can listen and enjoy. The first speaker I'm going to introduce is Dr. Muthaiah Srinivasan. He's a fellow of American College of Cardiology. He's board certified in cardiology, echocardiography, and nuclear cardiology. He has been in general cardiology practice since 2003 in eastern suburbs of Atlanta. His native is Ramati. Welcome, Dr. Srinivasan. We are very excited to hear about cardiac risk factors and how to prevent sudden cardiac death.
Thank you very much, Muthalagu, for the kind introduction. Today, the topic for my presentation is heart attack and sudden cardiac death, causes and prevention. As you all know, a little bit about the heart muscle is about the size of our fist. It's about a pound in weight and is located right behind our breastbone and to the left of it. It pumps about 5 quarts of blood every minute. And the function of the heart, of course, is to pump blood to circulate it throughout the body. The right side of the heart pumps blood to the lungs so that there is air exchange. We take in oxygen and give out waste carbon dioxide. After this air exchange, the blood reaches the left side of the heart. And from there, it is sent to the rest of the body, where all the cells of our body are able to take the nutrients and take in oxygen and remove waste. This supply of blood from the heart involves supplying for itself, for its own energy needs. Next slide. This is a picture of the location of the heart inside the chest. And there are two main things. One is the plumbing system of the heart, and the other one is the electrical system. On the below picture, you can see the plumbing, the path the heart takes to the right side of the heart, where the blue blood or the deoxygenated blood is processed, and then the left side of the heart. The other thing that we need to know is there's also an electrical system inside the heart. This is to help coordinate all the cells of the heart to beat in unison. The place where the heart's impulses for doing the heartbeat comes from a place called the sinus node, which sits in the right topmost portion of the heart. And the wiring takes the message all throughout. And this helps us keep the rhythm of the heart. The next slide. The topic was about myocardial infarction and sudden cardiac death. Sometimes people intermix both as being the same, but they are two different things. Where myocardial infarction or heart attack is when there is a reduction of blood flow to the heart mainly, whereas sudden cardiac death is where there is a sudden stoppage of the heart's function. And sudden cardiac death is sometimes a manifestation of heart attack, so they are interrelated, but they are not one and the same thing. Next slide. What is heart attack? When there is a death of a portion of the heart muscle, it's called heart attack. This happens when there is a mismatch between the supply of blood to the heart and the amount of the heart demands for doing its work. The most common mechanism where this supply-demand mismatch happens is when there's a blockage to the blood flow to the heart. Usually there is a plaque in the blood vessel that supplies the heart. On top, there is a formation of a clot that together reduces the blood flow to a portion of the heart muscles. But sometimes there can be spasm at a spot where there is a blockage. And occasionally, the supply-demand mismatch may not be due to supply, but to the demand of the heart. When the heart is beating very fast, or there is anemia and there's a requirement for the heart to beat more, these things can lead to a supply-demand mismatch. Next slide. See if it'll play. The voice is not coming.
It's 101.
I was just trying to show.
Maybe we put the mic next to it, maybe it'll show.
I don't hear anything from you.
Okay. It's essentially there is a plaque formation in the blood vessel that supplies the heart, and if the plaque ruptures, then there's a platelet-rich clot that forms at the same spot. And if a blockage happens at a certain spot, then the region of the heart that is supplied by that particular blood vessel dies, and this leads to reduction in heart function. You can go to the next slide. What are the in order to prevent heart attacks or to stay safe, we need to understand what is the underlying mechanisms or reasons by which heart attack happens. The predisposing factors that lead to heart attack include high blood pressure, diabetes, high cholesterol, smoking, obesity, and some minor risk factors such as type A personality, sedentary lifestyle, and of course, dietary habits contribute to it. If you look at South Asians, there is increasing understanding that there is an increased risk for heart attacks among South Asians. There are a couple of studies that show that 1 in 3 South Asians living in California have at least one major risk factor for heart attacks. And there is as a result, there is about a 3 to 5-fold increase in risk of heart attacks among South Asians compared to other groups. They also, not only there is a higher risk, this happens at a younger age. They have more, they present to the hospital at a later time, and they have a higher chance of dying once you have the event. That's because they tend to have what we call more anterior MI, which is blockage in the blood vessel that supplies the front of the heart, which is more important than the back. And also the blockages happen at critical blood vessels like what we call the left main, that is the main trunk that comes to the front of the heart. Also, patients have a higher reduction in heart failure after a heart attack. Next slide. Sedentary lifestyle is an important thing. If you have a sedentary lifestyle, you are twice as likely to have a heart attack compared to somebody who exercises regularly. The recommendation for exercise is at least 20 to 50 minutes most days of the week. Also, you want to choose the kind of exercise you want to choose is aerobic exercise. You at what level to exercise? You want to exercise at 40 to 85% of heart rate reserve. What is heart rate reserve? If you have a normal pulse around 70 beats a minute, suppose you are 50 years old, your maximum heart rate is around 220 minus your age, which is about 170. So this gap between 70 to 170 is the heart rate reserve. You want to exercise so that you get to at least 40 to 85%. 40 beats to 85 beats above your pulse, that is like 110 to 155 beats a minute. And when you are exercising, you want to have what we call the intensity of exercise. You have to feel the Bohr scale is about intensity, self-perceived intensity of exercise is between 1 to 20. Around 11 is somebody feeling it's mildly hard, to 15 is I'm feeling really hard to exercise. And this flow diagram indicates to some extent how exercise helps in reducing feeling of chest pains from blockages and improve our cardiac health. Essentially, increased exercise leads to increase in what we call stroke volume. What is stroke volume is the amount of blood the heart pumps with each beat of the heart. As we exercise, as we train, we are able to pump more blood per beat. And that leads us to need less heartbeats to do the same level of exercise. And next slide. Other important thing is dietary factors. Dietary factors, I would say that if you look at most of the studies, there are several different diets that are recommended, like the Mediterranean diet, the South Beach diet. But all of them, if you look at, they lead to what is the common sense recommendations as to follow in terms of diet. We want to increase the number of fruits and vegetables that we are using and switch to more whole grains instead of refined grains. We want to increase the protein from healthy sources like nuts, beans and seeds, and fish and seafood, and skinless poultry. This we also want to choose low fat or fat-free dairy and choose vegetable oils like olive oil or canola oil, which are rich in what we call monounsaturated fatty acids. We want to avoid polyunsaturated fatty acids and fatty acids that are fully saturated. Saturation refers to the number of fatty acids are compounds that have carbon atoms that are attached one after another and end up with an acid group. And if the usually a single carbon atom has 3 hydrogen atoms attached to it, instead if they have 2, and there is what is called, instead of a single bond, if there's a double bond, that is a monounsaturated fatty acid. And then there is this omega-3 fatty acids that are also helpful. There are 3 omega-3 fatty acids. These are essential acids because human body cannot produce them. Omega-3 refers to the third position of the carbon atom in the fatty acid where there is a double bond. Including garlic leads to reducing LDL, and that is the bad cholesterol, and also helping reduce blood pressure. And overall, maintaining a healthy body weight. We want to eat the right food, but we also want to eat the right quantity so that we are able to maintain the right weight. Then smoking. Smoking is not a huge issue among South Asians, especially among our community, but we need to be aware not to get into that habit. So diet and exercise are 2 things that are completely under the control of oneself in terms of trying to stay healthy. Then the other risk factors would need some modification and help from your physician. Hypertension, about 50 million in the US and about 1 billion people in the world have high blood pressure. Even a small increase in blood pressure that we sometimes seem to ignore have a significant effect on cardiovascular health. 20 millimeter increase in what we call the systolic or the top number, or a 10 millimeter increase in the diastolic or the bottom number will increase the cardiovascular risk by makes it double. So antihypertensive and reducing the blood pressure, it's one thing that blood pressure increases risk, but it's also that when we reduce the blood pressure, we also tend to reduce the risk for heart disease. You have a more robust effect on stroke, but there's also a reduction in heart disease by about 20 to 25% reduction in myocardial infarction and about 50% reduction in heart failure incidence when we control our blood pressure. And if you look at the effect, if you treat 1 patient for 10 patients for blood pressure over 10 years, you would reduce a chance of 1 death in that period. And of course, for blood pressure reduction, exercise, reduce sodium intake, increase calcium and potassium intake is also helpful. Next slide. Then high cholesterol. Cholesterol is a soft wax-like substance. The chemical structure of cholesterol is on the top. It is found in bloodstreams and cells, and it's a part of the cell membrane, and it is helpful for hormone production. Increased levels leads to both coronary artery or blockages, clots, and stroke. If you look at cholesterol production, 75% of most people's cholesterol comes from the liver, and about 25% is through dietary sources. There are three different kinds of cholesterol: the good, bad, and the ugly. The good cholesterol is the HDL cholesterol. The triglycerides are considered bad, and the worst is the LDL cholesterol. So most people who have had heart disease, we try to target the LDL cholesterol. And if you look at South Asians, the LDL cholesterol is high, but it's also used. There are different kinds of LDL cholesterol, and South Asians tend to have smaller, more plaque-forming cholesterol, and they also have less HDL cholesterol. And the HDL cholesterol that is present in South Asians is of the not very useful kind. HDL cholesterol is used to remove cholesterol from the cells and take it to the liver. And there is less of the useful kind in South Asians. So, and the level of cholesterol that we tend to, or we need to have in our body depends on our individual situation. If you have coronary artery disease or if you have diabetes, you are at more risk, and therefore the LDL cholesterol target that you need is lower than somebody with none of these problems. Next slide. Then the next risk factor is diabetes. Diabetes is due to the reduced action of a hormone called insulin. Insulin is something that is produced in beta cells that is found in pancreas in our belly. And it's either diabetes is due to either a reduction in insulin levels or due to the effect of insulin being lower. Diabetes is associated with 2 to 8-fold increase in cardiovascular events. But the problem is South Asians tend to have a higher incidence of diabetes. In a study that is there is about 20% prevalence of diabetes in Asian immigrants in a study done in Atlanta. And if you look at US population, the incidence of diabetes is about 10%. So we are about twofold higher chance of having diabetes compared to the Native American population. Next slide. The other aspect of prevention, there are not here, there's a situation called metabolic syndrome. This is a situation where there's clustering of risk factors. They're not all to the high level extent, but there is a combination of risk factors like slightly higher blood pressure, slightly higher inability to handle glucose, higher body circumference and stuff. This is called metabolic syndrome. This also increases risk of heart problems. Visceral fat is considered to be worse than fat on our bottom. And South Asians tend to have a higher visceral fat compared to fat in our elsewhere. So they call the apple versus the pear shape. And of course, smoking, mental stress. There are a few other risk factors that that are measured in the bloodstream called lipoprotein A, homocysteine levels, and high sensitivity CRP. These can be measured in blood tests if you have a strong family history of heart problem, but you don't have the classical risk factors for heart disease. You can check for these. If these are present, there are means to address some of them. Next slide. I'm sorry. Okay. I just wanted to show a video of cardiac arrest. Essentially, the bottom chambers of the heart have to beat in unison to be able to pump blood out of the heart and generate enough force to push the blood out. And this is by coordination, as I described earlier, with the electrical system of the heart. And in sudden cardiac death, this coordination suddenly stops because the heart is going at a very high speed or is going in a non-uniform way. Portions of the heart are beating while other portions are not. And so the heart is moving like a bag of worms instead of pushing the blood together. So this leads to, of course, lack of circulation, and the person doesn't last. And if the heart goes very fast, you have a situation called ventricular tachycardia, where the heart is going fast, it's still pushing blood, but then there is this ventricular fibrillation when the heart is not pushing any blood. The next slide. So, when you look at the EKG, this is a normal EKG where there's indication the top chambers are beating, followed by the successive beating of the bottom chamber. That's called normal sinus rhythm. And when a patient has ventricular fibrillation, you can have chaotic electrical impulses that can be detected on the EKG. The sudden cardiac death is the most common cause of death in the US, and it's about 500,000 people in the US have sudden cardiac death. 80% of them occur at home, and more than half of them happen while we are asleep. Only 2 to 15% of people who have sudden cardiac death are able to reach the hospital. And of the people who reach the hospital, half of them only survive at the time of discharge. And the most common mechanism is this ventricular fibrillation. Next slide. Of course, this explains why sudden cardiac death is the most common cause based on statistics from 2001. The most important factors affecting survival in out-of-hospital cardiac arrest is the time to resuscitation. And the next thing is the time to defibrillation. Defibrillation is giving an electric shock to the heart in order to reset. Well, I tell patients, this is like the computer. When your computer stops working, if nothing works, you turn the power off and you turn it on, everything resets fine. It's the same analogy. The electrical system of the heart is going haywire. You give a shock, you reset the entire, all the cells in the heart, and then it starts to work right. The next thing is the availability of AED in public has made a big difference. As you see, the time from onset of sudden cardiac death to the rate at which people pass away is pretty quick. It doesn't take much. The risk factors is the main risk factors for sudden cardiac death is in the inability of the heart to pump normally. We use a measure called ejection fraction. What is ejection fraction is? It's the percentage of blood inside the main pumping chamber of the heart that gets ejected during a single beat. If the heart starts, let's say, with 100 cc's of blood at the time when it starts to squeeze the blood out, and it comes down to 40 cc's of blood after it finishes squeezing, it doesn't empty the whole blood in the system, then the ejection fraction is 60%. 100 minus 40, 60 cc's for every 100 cc's of blood in the main pumping chamber. So the normal ejection fraction is about 55% or more. When there is a reduction in ejection fraction, usually 35% or less, it increases the chance of a person getting sudden cardiac death. And congestive heart failure, one of the reasons for congestive heart failure is symptoms when you have a low heart function. The function of the heart is two two things. One is it has to squeeze the blood out. That is called systolic function. And after it squeezes, it has to actively relax to pull the blood in so that it can prepare for the next beat. That's called diastole. It carries more energy than actually squeezing of the heart. So you can have heart failure without change in the systolic function. So congestive heart failure, whether it's systolic or diastolic, increases the risk for sudden death. Of course, heart attacks, and then the presence of certain irregular heart rhythms called non-sustained ventricular tachycardia, and history of a previous sudden cardiac death increases the chance of you having it again. Of course, family history due to genetics can also lead to increased risk of sudden cardiac death. Next slide. The conundrum for dealing with sudden cardiac death is that if you look at the total number of events of sudden cardiac death, they are the total risk is little very close to much less than zero, and the total events. We are trying, if we try to identify groups where sudden cardiac death is more likely to happen, you are trying to find groups where you can put your effort in to try to reduce the chance of it happening. But the problem is, if you identify a factor that leads to sudden cardiac death, but the contribution of that factor in the total population, what you call the population attributable risk is less. So if you have patients who have a heart attack, their chance of sudden cardiac death is good, but they constitute a small percentage of patients who will have that event. So your effect on reducing the problem is somewhat attenuated. In terms of what do we have for prevention of sudden cardiac death, we have certain medications that are available. We use in patients or who have a higher risk of sudden cardiac death. One is the beta blockers. This is a group of medicines that slows the heart and reduces the demand of the heart for oxygen. There's another medicine called ACE inhibitors and aldosterone antagonists. These medicines are commonly prescribed by your cardiologist if your heart function is low. 5 minutes. 5 minutes, thank you. And of course, smoking cessation. And then there is something called life vest and AICD. We talked about presence of defibrillators in the public. You would have seen in airports and in schools, most of the schools in the US, they have these things called automatic external defibrillators, AEDs. If you have a person who passes out, you can apply the pads on the person, and it automatically detects the heart rhythm and suggests whether they need a shock, and if needed, it can deliver it. This is for the public. But if you have a weak heart, you have a higher risk of dying from such events. You can have your own personal device that can shock you, and that is called automatic internal cardiac defibrillator. And when we don't know whether this person needs it, if a person has a low ejection fraction, we know they are at a higher risk, but we think they may recover with medicines. For short-term use, you can have a thing called a life vest, which is a jacket that will constantly monitor your heart rhythm and give you shock if needed. Next slide. The main thing you need to do is if you find a person who collapses, it can be both either sudden cardiac death or heart attack. The first thing you need to do is call 911, and you have to stay calm, take a deep breath. Don't panic. Step one is to stay calm. You have to follow your training. If you have done CPR training, you need to get the patient rolled over to a firm surface, and then you check for what we call the ABCs: airway, breathing, and circulation. And then if based on your assessment, you try to do the resuscitative measures that are called for. This is Yogi Berra that said, if you don't know where you're going, you will end somewhere else. Next slide. This is called the chain of survival. Death is a 4-letter word. We want to stop at 3. We call 911. We start CPR, use an AED, and then let the further system of care take over. And this is a picture of the patient with a defibrillator with wires down to the heart that will monitor and give him a shock if needed. And external defibrillation that is in public places. And this is like a picture of the life, what we call the life vest. And with that, I want to end my talk.
Thank you so much, Dr. Srinivasan. That was an excellent talk. As a physician, I learned a lot myself as well. Highlights being like blood pressure is a silent killer. Blood pressure, even reduction by 10 millimeter or 20 millimeter can save from cardiac death. And many other things like relaxation is important. Diastole in the heart. So we have 2 more speakers. So please save your questions. We're going to have questions after the end of the other 2 speakers. So we'll give you some paper to write your questions down so you can remember it, and then we'll address all of these questions in about an hour's time. Next speaker, Vandu.
Yeah.
Okay, next speaker is going to talk on the topic of attention deficit disorder, anxiety and depression. This is Dr. Ramaswamy Lakshmanan. He's both certified in general psychiatry and addiction psychiatry. He's a fellow of American Psychiatric Association, has been in private practice since 1990, predominantly treating patients with ADHD, anxiety and depression disorders. Native place, Sembanur. Currently working in private practice psychiatry in Houston, Texas. Welcome, Dr. Lakshmanan.
Good morning. Welcome to NPNA Medical Symposium. We want to thank you. I want to first thank Dr. Chillai for organizing this event. A lot of work. And I want to also thanks Dr. Mutharagu for giving me this opportunity to talk about psychiatry. So what I'm going to do is first talk about the stigma with psychiatry, and then I'm going to talk about the most common prevalent illnesses, ADHD, depression, and anxiety. So these 3 illnesses are so prevalent, and like Dr. Srinivasan said, the prevalence of hypertension is 15% in US population, and diabetes 10% in US population. I just heard that, and I thought about it. Depression is prevalence in the US population is 7%, anxiety 7%, ADHD 10%. So there's a lot of people have it, and you may know some friends who have it, but only thing is we don't recognize it, we are not aware of it, we are not educated about it. So that's the reason we are going to talk about it today. So first, I want to talk about the background of psychiatric field. When I started my psychiatric training in 1987 in Chicago, at that time, there were only 4 or 5 psychiatric medications available to treat all these illnesses, depression, anxiety, bipolar disorder. So we were struggling to treat the patient. And moreover, these few medications they had so much side effects, like they make the patient so drowsy, and they were, they had a dry mouth, and they said they were like zombie. So they could not go to work and function. So they did not take the medications. So if they don't take medications, they don't get better, right? So we didn't get many patients who were compliant in taking the medications every day. So it was a challenge. Then in 1987, Prozac was introduced to the market by Eli Lilly Pharmaceutical Company. That's the year I started my training. So since Prozac came to the market, it revolutionized the treatment of psychiatric illnesses because it was so amazing medication. It has only a few side effects. So people were able to take it, and they were alert, and they were able to go to work. So the compliance, the people was high. Patients were taking it every day, and they got better. And since then, we have had 40 different medications in the market. So today, psychiatry has grown. There's phenomenal growth and rapid strides. That's very good, right? And at the same time, in Philadelphia, Dr. Aaron Beck introduced the cognitive behavior therapy, which is the main psychotherapy we use today. So that's also started at the same time, 1987, 1990. So now, I want to talk about the stigma. 22% of US population have some diagnosable psychiatric illness, which is 1 in 5. So like I said, it's very prevalent. But only thing is, especially us, Asian Indians, we don't know about it. We are not educated about it, so we don't seek help. So when I see patients in my practice, the second generation Asian Indians, when I talk to them, and I usually ask the family history, right? So everybody, we have to ask family history, personal history, social history. So when I talk to our Asian Indian population, when I ask for family history, they say, no, nobody has. Father, mother, nobody, we don't have any psychiatric. It's so striking. But when I talk to Caucasian population, everybody will say they have the father alcoholism, mother depression, or sister bipolar disorder, right? So it's important to accept it and admit to it and get help. So 20% of the population have diagnosed with mental illness, which is 70 million people, but only half of them get help. Only half of them seek help. Why? Any guess why?
They don't accept.
Huh?
They don't want to accept, and they don't want to publicize it.
Right. They're not aware of it. They don't want, even if they're aware of it, they're being told, they don't want to accept it, admit to it. And also, those are the main reasons. But it's important to know mental illnesses is rapidly rising every year. With coronavirus, the psychiatric illness went up, the incidents, and social media. Young adolescents are getting more depressed and anxious. Especially female adolescents, they're comparing themselves with others. They have eating disorders, body image issues. Even last week, Surgeon General, he said we had to put a warning label on the social media because it is targeting young adolescents. And so the stigma, why stigma? Because weakness, shame, they're ashamed about it, and they're afraid that they'll be labeled as crazy, right? But actually, most of the psychiatric illnesses, the patients are crazy, right? They know what they're doing, they're fine, they go to work, they function. Only 0.5% to 1% of the population, they're psychotic and they don't know what they're doing, like schizophrenia. So only 0.5 to 1%. It's easy to diagnose, physical illness because you have a broken arm, you know that it's pain, you can do X-ray, but unfortunately, we don't have in psychiatry, we don't have any blood tests, lab work yet. We don't have any X-ray, MRI. So we go mainly by the patient's behavior, how they behave. That's the main thing. So I would like to say something here. You need to get help quick and early on. The reason for that is if you don't get the help early on, then the patient is going through suffering and pain, and emotional pain is very hard. Patients tell me how hard it is to go to the emotional pain. They cannot go and enjoy things. They cannot function at work. So it is hard. The second thing is, by treating early, you can help patients to function well in jobs. Then that way they perform well, and also in relationships and marriages, right? You don't want the relationships and marriages to be affected. And third thing is, if you treat the illness early on, the response is good. The patient gets better quick. But if they come late, I have patients who come, especially Asian Indians who come very late for treatment. And at that point, their brain structure and neurochemicals is kind of affected so much that it takes a lot to help them and treat them. So bottom line is smart to get help quick, because this is a demanding world. We have to function well. The boss gives you deadlines. So, you have a lot of, it's not like you can just take time off from work, because depression illness, the course is about 6 to 9 months. So next, I want to talk about the other disorders, ADHD, anxiety, depression. My overview and outline when I talk about these disorders is first, diagnosis. Second, prevalence and risk factors. Third, treatment. So the first is ADHD. So yeah. So this is a screening questionnaire we use, and we tell our patients to look at it. And if they have, about 6 to 9 symptoms of this, then they probably have ADHD. They have to go to a mental health practitioner for diagnosis and treatment. So the important points in diagnosis is they have to have 6 or more symptoms. Number 2, the psychiatrist would want to know if the children, and maybe children also adults, they have to have these symptoms in 2 or more settings, not only at school or home. Because at home, they may not show the ADHD symptoms. They may be getting one-on-one attention, or they may play video games. If they're doing something they like to do, they're not hyperactive. They can be calm and focus on what they're doing. So, but when they put, when you put them in a classroom with 10 people, or in university with 20, 30 people, they get lost. Their mind wanders. They cannot focus. So the main symptoms of ADHD is poor attention span. They cannot focus. They cannot focus. And second is hyperactivity. They cannot sit still. They're fidgety and they are running around. They're climbing. In adults, the hyperactivity is like they're fidgety and restless and tapping their feet. Third is impulsivity. They do impulsive things like buying things on impulse without doing research, and also they don't plan well. Like number 2, they cannot get things in order, right? So when I left Houston, and I have to do the get the parking or remote parking lot, get my air tickets checked in and everything. So but ADHD people, they cannot plan and organize. So now prevalence. The prevalence is that ADHD is attention deficit hyperactivity disorder, and ADD is attention deficit disorder. So the prevalence is 10% in children and adolescents. That's about 35 million people. And 60% of the children, they outgrow it. So by age of 16, 18, they don't have the symptoms, but 40% continue to have throughout the adulthood. And that's so the incidence in adults is 4%. So ratio, males versus females, 3 times, males have 3 times ADHD, ADD compared to females. And females are underdiagnosed or not diagnosed. Why? Because they present with only attention problems, difficulty focusing and paying attention. They're not hyperactive, running around, climbing, compared to others. So in school, high school, the teachers, they spot only the boys who are hyperactive and they call them and they ask them to go to the counselor, or they ask them to go and see the school counselor. But females are left out, which is not good, right? So women, the first time they're diagnosed when they go to university. In university setting, with so many people, like 50 people in a classroom or 30 or something, so they cannot focus. Then they have poor grades, and that's, I have seen the first time of women, girls diagnosed only at age of 18 or 19. But it's not good because in school they were not treated. So it's not a good thing for women. So then inheritance, 75% of ADHD, they have a families. 75%. So it runs in family. So if your parents had it, or if your sisters or brothers had it, most probably you're going to have it. So I have sometimes the parents come to see me for ADHD, ADD, because their kids have been diagnosed with ADD, ADHD the last year. So they think, oh, I have the same issue. So they read about it and they come to see me, and they of course have ADHD, and we treat them for ADHD at age 30, 40, 50. So, okay, then why treat ADHD? Why? Because they have, they have poor academic grades. I have patients, ADHD, they're in 5th grade, 6th grade. When we put them on medications, the grades go from, I've seen it, from C to A. So they lose the opportunity of those important years in academics. And job, with AD, people lose their jobs because they're not productive. And then relationships, it affects relationships. I have patients call me that, hey, my girlfriend wants me to see you because she says I'm always talking. I'm not listening to her. Yeah, she tells me to buy something from the grocery store on the way, and I forget, and she gets frustrated.
The other way around.
And then low self-esteem. ADHD kids not treated, they have low grades, and they have low self. It's a big deal, low self-esteem. And then they go on, and what they do, they go to alcohol and drugs. They go with the bad crowd. They're not with the crowd with good grades, right? And then accidental injuries. They're climbing, running, they get injuries. And then traffic violations. They're impulsive, drive fast, speeding tickets. So the treatment is counseling. Again, like I said, CBT therapy, cognitive behavioral therapy. This therapy we use for most of the illnesses. So that's for treatment, for counseling. Counseling helps, but ADHD, ADD patients, they definitely need medications. So the most commonly prescribed medications is stimulant medications like Adderall, Vyvanse, Concerta, and they're controlled substances. The problem with them, they're very effective. The thing is, it can be habit forming, but most of the patients I've treated, they don't abuse it. They take it as prescribed, they do well, and it helps them. And you can take it as needed. You don't have to take it every day. There were some concerns about heart problems, side effects, and growth retardation 30 years ago, but they did studies and they proved so it doesn't cause any heart issues. But if you have a family history of heart disease, or if the kid or the patient has a heart disease, then you have to, think about it. And it can cause loss of appetite, insomnia, headaches, so blood pressure problem, these are things. And there's another medication which is non-stimulant, which is not habit forming. It's called atomoxetine Strattera, and that is not, this is a little bit less effective. It's a good medication too. It's good for patients who have substance abuse disorders like alcohol or drugs. And also, this medication helps anxiety too. So if somebody comes to me with ADHD and anxiety issue, then I would go with Strattera. So when I was in private practice for 30 years, I prescribed a lot of stimulants, Vyvanse, Adderall, very good response. Patients get better quickly. But with the other medication, Strattera, it takes 4 to 6 weeks, to see a good improvement. So nobody, so that it's been there for 30 years, but it's not popular. But since I started, the last 5 years, I started my telemedicine practice. So I cannot prescribe controlled substances. So I'm prescribing a lot of Strattera every day. I have a new patient for ADHD in my telemedicine practice, and I do mainly all over Texas. We get so many patients with ADHD, 1 or 2 patients every week. So I can prescribe only Strattera, and I've been doing that, and it has been helpful. I did not use it, I did not prescribe it before, but now that's the only thing I can prescribe. I can see patients getting better. There are a few patients who don't respond, but many of them respond and do well. So next, let us move on to depressive disorder. I don't know how much time I have. How much time?
10 minutes.
Huh?
Or, 14 minutes. 14.
14.
we go, okay.
So this is a major depressive disorder. It's very important illness. It's the way it's diagnosed. Yeah, this is the way you diagnose. It's important to know that to be diagnosed with major depressive disorder, you have to have you have to answer more than half the days. Number 2, either for question number 1 or 2, you have to have that one symptom, at least one, either 1 or 2, not 3 or 4, 1 or 2. And then you have to have 4 or 5 symptoms. So if I want to quickly diagnose depression, what I ask is, hey, have you been feeling depressed, down, or sad almost every day for the last 2 weeks? If they say yes, most probably they have depression. If they say no, then I ask the next question. Have you lost, the first one, have you lost interest or pleasure in doing things that you always enjoyed doing things? Like somebody likes to do gardening, or somebody likes to go to gym. They lose interest in it. They don't have desire to go. So this is, if this answer is no to both those 2 questions, then probably they don't have depression. And then we ask other things. They have trouble sleeping, you can read yourself. So when it comes to sleep and appetite, younger population, adolescents and young adults, they tend to sleep more when they're depressed, as opposed to elderly, older adults. They sleep, they have problems sleeping. And when it comes to appetite and overeating, younger adults, when they're depressed, they eat more and they put on weight, as opposed to older adults, they lose weight. And some of the symptoms has to be observed, right? In children, instead of being depressed, if they're irritable, that's enough to diagnose. Instead of feeling depressed, if they say I'm irritable, if you see them irritable, then they could have depression. So prevalence of depressive disorder is 7%, which is maybe 20 million people, I think, 20 million. And the females, twice as common as males. Again, can anybody say why? Women, twice as common as male for depression.
They speak out more. They speak out more often, or they talk about their feelings more.
The incidence, I'm talking about incidence twice as common as in men. Because hormones is the main thing. Yeah. So when women start having menstrual periods, then it starts. They have more, the risk is more. For women, premenstrual disorder, we see patients, right? 4 or 5 days before their menstrual cycles periods start, they get depressed, irritable, upset. Then it goes on for another 2 or 3 days. Then after they stop the menstrual periods, they're fine. So sometimes, a lot of women have that, but some women have it so bad, it's called premenstrual dysphoric disorder. And the good thing is, it's good treatment. The same medications for anxiety and depression will treat premenstrual symptoms, like lexapro. And also postpartum, women are more common. Very important. It's very important. After the child is born, they are at risk for the first year. They are at risk. Some people, they're so depressed, they cannot function. And then again, hormone fluctuation in perimenopausal period, like from age 45 to 55. Age 45 to 55, they start having depression, being emotional, upset, irritable, and they have night sweats, hot and cold flashes. So again, all this can be treated with medications. So then the next vulnerable population is young adults, age 18 to 25. Again, why? Anybody can say why? Age 18 to 25. Why?
Pressure of life, college, studies, they have to go out and learn, earn, right?
You're right, right. You're correct. You're right. You're right. Yeah,
College,
college, academic demands, they have to do well in school and social demands. They're navigating romantic relationships, they have breakups and they have hormonal issues and they start experimenting with drugs. They're worried about finances, jobs, and the brain growth is not complete until age 25. So that's a very vulnerable time for them. After 25, the resistance goes down. And social media is another one. So then the risk factors. The risk factors for depressive disorder is again biological, which is genetic, 60% heritability. So if you have somebody in depression, 60% chance that you may get it. So when I see patients, and ask family history, almost every patient will say that they have parents have depression, anxiety, alcoholism. When they say alcoholism, they may not have pure substance abuse. It could be because they're self-medicating the depression with alcohol to the point they drink so much alcohol. Second, psychological reason, risk factor is personality problem. So some patients have always had a timid personality. They are very clingy, dependent personality. They are at more risk of getting depression. Third factor, social, environmental, job stress. Every patient comes to see me, they say job stress. And my job is very stressful. As if they think that their job is the only job stressful. I'm like, hey, my job is stressful too. Everybody says, hey, my job is very stressful. I said, in America, you live in America, every job is stressful. That's what I think. So, job and marriage, another important, all the time, patients have a marriage problem, relationship issue, breakups, finances, grief. So these are the social environmental factors. Fourth, medical illnesses can cause depression too, like diabetes. I saw in your slide, depression is one of the risk factors. Heart disease, people after a heart attack, they get depression more common. Stroke, Parkinson's disease, brain illnesses, dementia, very common when they have Alzheimer's disease. The last important risk factor is childhood trauma. We see so many patients with childhood trauma, especially sexual, very common, women, females, sexual trauma, physical trauma, and emotional abuse, verbal abuse. Going to, they see the parents fighting all the time, being scolded, being put down. So that's the trauma, very important risk factor. So treatment.
You're fine.
Our 6 minutes left.
Okay, so treatment. The first one I want to talk about is 6 pillars of lifestyle. It's very important. I want everybody to know this, all of us. Number 1 is exercise. This is called 6 pillars of lifestyle. And American Psychiatric Association, their theme this year and next year is they want all of us to focus on these 6 pillars of lifestyle. And they think that if you follow these 6 pillars, you won't have any mental illness and physical illnesses. So number 1, exercise. Number 2, eating healthy food, preferably plant-based food with no preservatives or additives, and then reducing your stress level. Number 3. Number 4, avoiding harmful substances, alcohol, drugs. Number 5, sleep. And they say restorative sleep, not just sleep, good deep sleep. Number 6, social connectedness. I think social connectedness is very important too. When it comes to mental illnesses, you have to have social support network, systems, family, friends. So it might, when I talk to my patient, we always ask about who is your emotional support system? I have every patient, the new patient, we ask about it. So most of them say, family, friends. If they're isolated, if they don't have somebody to talk and vent out, or even just talk on the phone. Hey, how are you doing? What did you do today? Social support system, very important. Okay, next. the first, when somebody is depressed, mild to moderate depression, we tell them go to psychotherapy. And the most common therapy is CBT therapy, cognitive behavior therapy. Discovered by Dr. Aaron Beck from Philadelphia in 1985 to 1990. So what it is the patient goes and tells the doctor about their current problem. They talk about their current problems, and they say, okay, my boss is not nice to me, and he's not giving me the promotion. So, he's singling me out. And so what the therapist does is ask the patient to identify, recognize, and be aware of their negative assumptions. And because of the negative assumptions, they get depressed or anxious. So the therapist tells the patients to identify the negative thoughts which they're having and put them in right perspective and think about it based on facts and reality, and tell the patient, hey, he's not singling you out. He gave a promotion to another worker because he was well qualified than you. So that's the way CBT works. So treatment is with the most commonly prescribed medications is SSRIs, which is selective serotonin reuptake inhibitors. And the most commonly prescribed medication for depression and anxiety is Lexapro, which is escitalopram, and Zoloft, which is sertraline. So these are most common. They've been there for 35 years. They have good safety record, and they work. The first week, you can see some improvement in the first week, and it takes about 6 to 8 weeks for full effect. And they're not addictive. They have only mild side effects. One time they wanted to make it as over-the-counter drug, but then they did not do it because, for some reason. So I see cholesterol medicines being taken. So many people take it for what? For preventing heart attack in 10 years, 15 years, 20 years. But why don't they take these medications? It can help you and feel better right now. And their side effects are very few. I see so many patients. The first week they may have a headache and nausea, sleepiness, and after that, no problem. Right? Easy medication to prescribe. So I tell my patients if they're hesitant. I don't know why. They think, okay, I'm labeled as a crazy guy. Right? So I tell them, hey, take it for a week or two. You'll see some improvement. If you're happy, continue taking. So yeah. So then, last is anxiety, and anxiety is, again, for diagnosis of anxiety, the most important thing is question number 1, 2, and 3. If they don't have that, they don't have anxiety. So they have to have feeling anxious, nervous, and worrying too much, not able to control the worrying, and it has to be present for at least 6 months, and then you have a couple of symptoms. And this is 30% genetic. Is again more females than males, and the treatment is the same thing. SSRIs, same medication. So medications like SSRIs, selective serotonin reuptake inhibitors, like I told you, Lexapro, they're not only good for depression, even though they're called antidepressants, but they're not only good for depression. They're good for anxiety, OCD, PT. OCD means obsessive compulsive disorder, post-traumatic stress disorder, eating disorder, bulimia nervosa. They are given for so many different conditions. For anxiety, only different is, you can give another medication called buspirone, and also benzodiazepines like Xanax, but it's not recommended, Xanax. You can give it as needed. If you don't want to have them take every day because it's habit forming and addictive. It can cause drowsiness, some memory problems. So it's not recommended. Thank you for your attention. If you have any questions, you can ask me. And this are some resources I put. I tell my patients to go to the Mayo Clinic. They have, if you have any questions, read about side effects of medications. Mayo Clinic is good. They have side effects of all medications. They have good write-up about depression, anxiety, and Medline Plus is for side effects. These two are for general information about psychiatry And this is, if you want to get any, if you want to find a therapist in your local area, counselors or psychiatrists, this is a good and best website to go.
Thank you, Dr. Lakshman, for that insightful talk. Actually, people don't realize it's a very common problem. Need to seek attention, and you can make a big difference. All the chettiers here, menopause undergo pandra aachingallam konjam be nice to them and help them overcome all of their depression symptoms.
Be nice to the husband or to the patient.
அதே மாதிரி இங்க young parents இருந்தீங்கன்னா remember Dr. Lakshman சொன்ன மாதிரி treat the kids well so they don't have undergo any abuse or anything, and all of that will make a difference in their long-term lifestyle. So இப்போ next speaker, which I think everybody is looking forward to hearing from, Dr. Muthu Arunachalam. He's a geriatrician and primary care physician. He's board certified in internal medicine and geriatrics. He has been in private practice since 2002 in Livingston, New Jersey. He lives with his family in Montville, New Jersey, and is a native of Arimala. He's going to talk about navigating healthcare after retirement. அதுவும் யூஎஸ்ல வந்து பாத்தீங்கன்னா there is so many things going on. எதை எடுத்தாலும் you don't understand what is there in the beginning, and then you go there, oh, you have this bill, you have that bill, you have next to this. So he's going to help us try to understand what to look for and how to navigate this. Thank you. Welcome, Dr. P. Any questions? Questions for speakers?
Good morning, everybody.
Good morning.
This topic, I just took it because I know in my practice lot, I hear a lot of people asking me questions. I'm not a kind of a Medicare specialist or a broker. That's where you need to go when you're really seriously looking into getting the medical insurance. But anyhow, I thought I'll go over most of the questions. I usually answer my patients. And sometimes I get to consult with the hospital and social workers and things like that, and to get that done. The rationale behind this question topic was many times I get this question: what's the right time to enroll in Medicare? How to avoid losing money when signing up with Medicare? Both coverages and penalties are there if not choosing the right plan. What's the difference between Advantage plan versus supplementals, cost associated with Part D prescription plans, and how to avoid permanent mistakes. Medicare eligibility, as you probably would all know, begins at the age of 65. That's for 90% of the people when they right time for retiring. Some people do work longer than that. But for some, they are eligible before the age of 65, and that's a very minimal 10% throughout the country. Basically, who have some physical illnesses like end-stage renal disease, ALS, also psychiatric illnesses and emotional diseases. They are eligible if they get Social Security disability continuously for 24 months.
I don't speak up.
Yeah,
Use the mic.
If they are eligible through Social Security disability, if they receive for 24 months continuously, the 25th month, Medicare automatically sends Medicare A and B card to them. The main eligibility for people who are after the age of 65 is if they had worked for 40 quarters throughout their life, or cumulatively for 10 years. They have been paying their taxes, and Medicare taxes are part of that. If you have not been working for 40 quarters or 10 years, you can also get eligible, especially through your present spouse or ex-spouses. There are criteria on that. How old they have to be, both the ex-spouse or the spouse, and eligibility from there. What's the right time to enroll? Basically, at the age of 65 and no longer working, either self or spouse. That is, if they are not having any medical insurance through their employer, I think they are eligible to get the Medicare, both Part A and Part B. Many a times, if they have some insurances, that I'll go later on, they can probably get A alone and wait for B later on. There are some special situations where, patients, they have COBRA insurances, TRICARE insurances, that's basically military insurance, small employee employers like less than 19 or less employers who have that many amount of employees, they might not have a good program, and they might probably need to enroll into Medicare. ACA plans, I know ACA plans, some people still stick on to that because premiums might be lower, but the caveat there is that at the age of 65, the financial benefits from ACA are less, and they mostly go away, and cost gets larger, and as a result of which, the ACA does not give any further benefits, and at that point of the time, taking Medicare will be much more better for them. There is some terms here, which is basically called as IEP, initial enrollment periods. Usually it's a 7-month we talked about. That starts from the 3 months before your birth month when you get 65. So the month you get 65, 3 months before that and 3 months after that. That's a 7-month window period where we call the IEP, which is the initial enrollment period, where you got to sign up for Medicare. If you're not doing that, you might end up with penalties. So that's the right time that you need to get enrolled into Medicare. Who may opt out of Medicare enrollment? Who may? Basically, sign up is not required for these people, but still it's a good habit to sign up if they want to. Basically, if you are more than 20 employees in a job and the employer is giving you insurance, you can compare the cost of the premium, the deductibles, the maximum out of pocket expenses, treatment cost. If it makes sense for you, you can stay with your insurance that the employer is giving. Otherwise, you might probably want to take Medicare. The terms are that your employer must help to move if you want to make a move. I'm talking about the insurance part of it, not the job of it. These are people who are not required to sign up. Basically, they are have part of a larger employer plan. They can enroll at a later stage. The reason why they don't need to is because they have a good insurance from their employers. The reason why they want to prolong this, because if they they join the Medicare at this point in time, and they cannot re-enroll afterwards. The clock already starts once you join. So if it's a good insurance package from your employers, you can delay your sign up. Once you get retired afterwards, then there are other times where they call it as a special enrollment period. That's after retirement. You have up to 8 months without penalty to sign up for Medicare. There are some people who use the special enrollment period category, especially when they are moving, when they lost the coverage, either from losing a job or they retired after 65, getting married, adopting a child, several clauses where they can use the special enrollment period category for that. Sign up is easy. Enrollment to Medicare is just either online or going to a Social Security office and signing up. But the main thing is that when you sign up, what are you signing up for? Basically, the 3 options which we'll go over one by one. The first thing is just to get a Medicare A and B. Then the second would be to to get A and B with a supplemental plan, which is an RX plan. Then A and B replaced by Part C. For the third option, you will need to get the help of independent insurance brokers. The caveat there is that many of them are biased, and you got to really know what what the person is telling you, and how much informed you are. The reason why they can be biased is that their first year commission, I heard, they get the most out of the Medicare from when they sign up. So they might probably push you to something that you might not like it, and that's going to hurt you. So information is more important at that point of the time. Yeah. Now Medicare A. Medicare A is the one which you do not pay any premium. This is where you got your work and you paid your taxes for, and at the age of 65, you were eligible to sign up for a free Medicare A. That covers the in-hospital care, skilled nursing facilities, rehabs, hospice care, home health care, and if you're scheduled for surgeries in hospital and for pre-op testing, Medicare A covers all these services. They are premium free, as I told you, if you had already paid taxes for that 40 quarters and the 10 years of work. There are some people who have not done that, and they might, there's an option for them to pay premium and get Medicare A. That option is also there. The deductible in Medicare A is basically, they calculate on 3 different sections. 60-day benefit period, which is basically that when you get admitted to the hospital, that first day is counted as day 1. And up to 60 days, you could have gotten discharged, or you would probably still stay in the hospital. That 60-day period is considered to be one single period. So the deductible is $1,600 for that benefit period. And after that, if you're still continuing to be in the hospital, the co-insurances increases. Days 61 to 90, you're almost, I think you're supposed to pay around $400. If it is 91 to 150 days, then this is continuing in the hospital. I think you're probably supposed to pay around $800 a day, and beyond, then you would probably pay more part of it. So these are the deductibles on the fees that you are supposed to pay, even with your full Medicare A coverage. And Medicare B, these cover the outpatient and physician charges, lab services, wellness and preventive services. They also include vaccines, which are eligible for wellness and preventive services, ambulance and outpatient care, durable medical equipments, non-self-administered medications. This is not your RX plan. These are medications like infusions, chemotherapy, which are not that directly you can go and get it in the pharmacy. They are administered by physicians in physician offices, in infusion centers. They all come under Medicare Part B. Outpatient surgery nowadays, many people are not getting surgeries in the hospital. They're getting same-day surgery in surgical centers. That is all covered by Medicare Part B. Medicare Part B is not a premium free. At the present rate, you have to buy Medicare B after you get Medicare A. At present, I think the rate for this year and previous years have been $164 change per month right now. I think it might probably slightly go up every year because of the inflation and things like that. 164 is only a base rate, but depending upon your income category, it might go up. There are surcharges for that. That's one term here. They use the IRMA, which is the retirement medical adjustment rate, which is a surcharge, which includes a lot of factors, where there's age is included, the area where you are staying, that gets included, and your income levels also get into the factors for calculating that. And there are some deductibles here. The deductible is $226 per year at this current stage. It might change later on. Co-insurance is another term that we use for Medicare B. When it's an accepted service, which is a covered service, 80% is paid by Medicare and 20% is your co-insurance. So you have to meet your deductible first, and then will be your co-insurance, which is your 20% that you have to pay. And these are all usually automatic. Once Medicare is accepting to pay for that coverage, automatically the rest of the 20%, will be sent to us, the patients, to get that paid. There are financial risks in Medicare B. There is no maximum out-of-pocket limit, and that is the biggest risk of Medicare Part B. And that's the reason why many people, they don't start with this, they go for other coverages afterwards. Because this, when it started, I think the federal government did not think that Medicare A and B are going to be the standalone insurance for people who are retirees, and that's why this was designed like this. So there is no maximum out-of-pocket limit. So it could be, you could end up in big bills, with Medicare B if you do not have any other additional coverages. Medicare A and B that we just talked about, the combined is called the original, the traditional Medicare. The two greatest benefits of having Medicare A and B are the freedom to seek any physician in the US and its territories. Basically, almost 98% of the physicians accept Medicare coverage fee schedules, that becomes easy, and also there's no interference by any insurance company. It's just between you and your doctor who makes a decision. So basically, any physician who is accepting Medicare fee schedule, you can go and seek the services for the physician fees. And also, you can go to any hospital throughout the country in case if you need hospital admissions. The decision is made only by patient and the doctor, and no other interferences. So these are the two major benefits by having the original Medicare, traditional Medicare. And the terms here, they become important as medically necessary services. It's not that every service a physician or a hospital does is going to be paid, from the Medicare's terminology. Are they medically necessary? There are some surgeries, like for example, cosmetic surgeries, some Botox surgeries, and things like that might not be felt medically necessary by the Medicare, and so that might be denied. Sometimes you have a physician billing, and Medicare thinks that was not medically necessary, as a result of which that might get denied. So medically necessary services are the ones which will be covered by these traditional Medicare. Then we have this Medicare C, which is basically the additional coverage after Medicare A and B. That's the Medicare Advantage plans nowadays. That's the name they use it right now. This one replaces Medicare A and B. I mean, you trade Medicare A and B to the Advantage plans. And so they will take away your Medicare A and B, and the insurance companies will start giving you plans. They are the Medicare Advantage plans. They are run by for-profit insurance companies, because for them, saving money and profit is their motto. But anyhow, it's been built with discussions with the federal government, and that's how you get all your benefits from these Medicare plans. Still, you need to pay premium for Medicare B. The IRMA surcharge will still apply. So those you will pay directly to the insurance companies, so you still have co-pays, deductibles, co-insurances. It's not that sometimes they call Medicare Advantage plans as $0 plan. They are not $0 plan actually. You still have your co-pays, deductibles, co-insurances. You still have to pay as you go. But there is a maximum out of pocket expenditure, which is basically at this time, it's $8,300 for in-network and 12,450 for out of network benefits. So that would be your maximum out of pocket expenditure. Some insurance companies, some plans have lesser MOP, as we call that. But that depends upon the area where you live in, the insurance companies that you are getting the insurance from. Again, approved services are only covered. Again, here the approved services are not what the Medicare A and B has described. It's what your insurance company is going to say right now, which are approved. So that is what is going to be covered. What your insurance company is deemed as having medically necessary. There are a lot of discussions, and this is one of the most important discussions we have when we are having the drawbacks for the Medicare Advantage plans, that many plans will not approve it just directly. They will have a lot of prior authorizations, they have denials and things like that. But that's an ongoing fighting with the patients, with the physicians, fighting with the insurance companies, and trying to make eligible. This is like for many of your patients, and I will know that this is an ongoing battle. We have to take up the phone and talk to the insurance companies. If they're not approved, sometimes patients themselves do that. Again, for the approved services, it's covered. But if they're not approved and you still go for those treatments, the patient has to pay that out of pocket. That will be 100% out of pocket expenditures for them. Cost varies again, depending upon the place, age, and availability of plans. I think there's almost like 4,000 plans throughout the country, and at any given geographical area, there's almost like 40-50 plans that you can choose from, whatever is mostly fitting into your need. And that's where those Medicare independent brokers come into place. So you may probably want to discuss with them, which might be the right plan for you, considering the need that you are in, the medical disease that you have, and other factors like, are you going to be in one single area? Sometimes you can travel, and these coverages might not fit in. So those factors are there when you plan which one to take in the Medicare plans. There are on a broad selection, there are two options in Medicare. See the Medicare Advantage plans. Either you can take a PPO plan or an HMO plan. The PPO and HMO plans, they are exactly like the same PPO and the HMO plans that you have when you're taking your regular medical insurances. PPOs are the larger networks. They don't need referrals from PMDs. They can see a specialist also without a referral. So that's the PPO plans. The HMO plans are smaller network plans. They need referral from PMDs, and they might be a little bit more cheaper compared to the PPO. But depending upon what your needs are, you might want to take one of that. Again, these plans, they mostly do not have any out-of-network benefits other than just emergency or urgent care services. And the drawback here is that even though 98% of the physicians in this country might take Medicare fee-for-service acceptance of the fee services, only 46% of MDs are accepting Medicare Part C Advantage plans. And again, you might have a different Advantage plan, and the physician that you might want to go might have a different Advantage plan, where they participate in. So so that's where the risk becomes, that if you might not be able to see the same doctors that you want to see, and so you're forced to see a physician which are there in the plan list, basically. Mostly the benefits are they talk about the zero premium or low premium. Right now, I think on average country premium average is around $18 per month, but that might not be in individual's case, because it differs again due to age and area of your living and other factors. They also cover all the medications and infusions as the Medicare B list says here. This does not cover the prescription medications, but it covers all the medications and the infusions which are in the Medicare B list. How this works is that you pay, the premiums that you're supposed to pay, you'll pay your insurance company if you take the Medicare Advantage plan. The federal government basically gives $12,000 to these Medicare Advantage plans, insurance companies per year per person. And sometimes it might be more or less, depending upon individual patients who are frequent users, high coverage users, and that there might be some changes that government is paying Advantage plans for taking care of you as a patient. The perks are from the Medicare Advantage plans are they cover dental, vision, and hearing. The traditional Medicare, which is Part A and B alone, does not cover these kind of perks. And the drawbacks are the two great benefits are lost. There's delay or denial of services can be there, and that's where you got to fight or discuss with the insurance companies about getting the coverage. The denial is basically the control expense. Sometimes they will cover a benefit, but the benefit length is cut short. That's another problem where we see depending upon length of stay in hospitals and length of stay in nursing homes for skilled nursing and other factors. And there's another term here, annual enrollment period. That's where if you don't like your plans or if you don't like your Medicare C or D plans, you might change. That's October 15th to December 7th of each year. And that's when you can switch your plans going forward to start from January 1st of the next year. So, this is Medicare D. This is the prescription plan. And this covers all prescription medications. They vary according to formulary. Sometimes you might feel that after A, B, and C that you might not need, like for example, you're not taking any medications, and you might feel that, oh, I don't need a Medicare D. But they have a Medicare has an inbuilt caveat in that they have put it that if you do not enroll, when you're taking your Medicare A and B and the C, if you do not enroll in Part D, then you might pay high penalties later on. Many people advise to at least take a low cost plan, and then you can change it during the yearly enrollment period. If you want more or less, depending upon for other years. The deductible is $545 a year. Initial coverage, the coverage is up to $5,000 about. And then there is something called as a donut hole, 25% copay until $8,000. I think, I heard that for 2025, they have eliminated this donut hole. So I'm not sure how the new will work from 2025. But yeah, they're taking out the donut hole for the next year. And catastrophic coverages, if it goes beyond that, you have a $0 copay. Again, you can switch plans October 15th to December 7th. Medicare supplemental plan is another one. This is built on after Medicare A, B, and D. This is not the Medicare Advantage plan. So either you can take Medicare Advantage plan after your Medicare A and D, A, B, and D, or you can choose the Medicare supplemental plans. This is basically for ease of use. The private insurances, they give you Medicare supplemental plans after your original Medicare. It's like basically like a dummy insurance. It does not do any other planning. All it does is that it pays your deductible, your co-pays, your co-insurance that Medicare does not pay. That's why it's called as a Medigap, because whatever those gaps from your traditional Medicare are, it fills the Medigap. There are about 10 plans throughout the country. At present, Plan G and N are popular. Once enrolled, the benefits cannot change. So it's like for your lifetime, you get those benefits. And so that's the benefit of enrolling into your supplemental plans. The drawback is that there is a monthly premium for that. I think it's around $125 per month up or down. And you have to enroll within 180 days of your initial enrollment and not to wait longer. Medical supplemental plans, as I told you, the G plan is, I think it's better, because it pays 5 of the 6 gaps. and the plan N pays 4 of the 6 gaps. The gaps in Medicare A, let's just explain that, is $1,600 per 60-day period. Extended period of in-hospital stay will be amounting to $400 to $800 per day. The skilled nursing facility co-pays are $200 per day in Medicare A. In gaps in Medicare B is the deductible of $226 per year. The co-insurance we talked about 80%, 20%, and sometimes physicians bill excess of 15%, and that the patient has to pay in a traditional Medicare. But in a Medigap, in the supplemental plan, the 5 of the when you take the G plan, except the deductible of 226, all the other gaps are satisfied. And I think in plan N, the deductible and the excess is not covered. The rest of the other 4 are covered. Yeah. Switching between plans. That's going to be difficult from one way to another. Basically, if you take the Medicare Advantage plan, initially, changing to supplemental plan is going to be very difficult. You might get negated. You might be considered not eligible. They need an underwriting afterwards. So many brokers say that to please get the supplemental first if you're not decided which Medicare Advantage plan to get. So basically, supplemental is like building upon your A, B, your D, and then you're going to get a supplemental plan. Basically, just going to fill up your Medigap, and it does not need any underwriting initially when you switch into Medicare. At the age of 65. But if you take up a Medicare Advantage plan and you don't like it, going back to a supplemental plan is going to be very difficult. They might even make you not eligible, and that you may pay very penalties, or you might need to end up with ones which you don't like. Some comparison between supplemental and Advantage plan. Supplemental plans, even though they are, it's good, but thing is that premiums are high, and the Advantage plans have a lower premium comparatively. There are other coverages in Advantage plans like dental, hearing, and vision, which supplemental plan you have to pay a monthly premium for those things. Other perks are there, gym and transportation and things like that are not covered in supplemental. Advantage plans are limited only to service area. Like for example, a lot of retirees go from state to state, like summer state and winter state. You have to call and let them know in advance that you're switching from one Advantage plan of Florida to New Jersey, or to Florida to Illinois, depending upon where you are going to be for that few months period. But whereas the supplemental plan, you don't need to worry about it because it's covered throughout the country, because it's still a traditional Medicare. So on that basis, supplemental plan becomes unlimited networks, whereas in Advantage plan is a limited network. We talked about the physician-patient controlled, which is the freedom that you get in having a supplemental plan, whereas Advantage plan has been administered by insurance companies. So you get a lot of denials, and they're going to give you a say. It's not what your doctor is going to say for you. Multiple cards needed, whereas here it's a single card. In Advantage plan, you don't need to carry several cards like what you do in supplemental card. In supplemental plan, there is no prior authorization required, but whereas in Advantage, as we spoke about, a lot of prior authorization is needed. Sometimes denial can be done from the Advantage plan by the insurance companies. And the cost sharing in supplemental is 100%, but in Advantage plans, you still pay as you go. Your co-pays, your surcharges, your co-insurance still are in play. But the good thing about supplemental is lifelong coverage. But here it's annual. If you don't like it, you want to change between plans, you might probably do it during the annual enrollment period between October and December. And this is the last one. Myths in Advantage plans. Many people talk about it's a zero cost, which is wrong. The true cost, which is hidden, which many times the brokers don't say, is hospital copay in Advantage plans are still around $300 a day. Specialist copay is $25 to $40 a visit. If you're going for a scan, they cost about $250 per scan. Sometimes outpatient surgeries, they charge you around $300 for each surgery. for durable medical equipment that you're ordering, your wheelchairs and your crutches and your walkers and home-based DMBs are 20% insurances, hospital bed for an example. Then for skilled nursing facilities, you still have to pay $200 a day if you're going to rehab. That's about it. I mean, I know it's a lot of things to cover, but for many people at this point of the time, it's not that you're going to make a decision tomorrow, but when you're ready at that time, these factors might come into good amount of information at that time. But the thing is that Medicare is evolving. They still do some changes, small changes, every year, and they go by it. So, at that point of the time, some changes would have been there. Anyway, thanks for listening.
The best option is stop aging at 65.
What options do we have for folks below 65?
What's that?
What options or kind of insurance options do you have for folks below 65? Medicare.
Below 60, Medicare doesn't cover.
I know.
Yes.
Are there any private insurance?
Private insurance is what it is.
Enroll in a HMO, can change after
Now it's 70.
HMO plan of Medicare Advantage plan.
Yeah.
Yes, the annual enrollment period.
You can change.
You can change that to
Somebody said after HMO, you cannot change once you sign up.
No, you can't go back to a supplemental plan because I think they'll give you hard. The reason why is that, see, when the reason why you might change from HMO plan to another plan is because you are going to need some services.
Right.
So, okay, so supplemental plan is going to know that, and so Medicare is going to think that you're coming back there because you're going to get new things, so they will make you ineligible for supplemental, and so that's the catch there. Yeah, sorry.
It's a good kind of person.
Thank you. Chief, we can sign there. Thank you.
Questions and then we'll start the forum also.
Thanks a lot, Dr. Arun. A very complex topic, very well simplified for us. I'm hoping this will be of great help to everyone. The thing I got out of this is Medicare Advantage Plan be warned. It's not what it seems to be. You're probably better off using a supplemental plan if you want to have the coverage for co-insurance, copay, than everything else. And feel free to ask questions now. We gave you flashcards. If you have written questions, we can take it and ask questions, or we'll pass the mic around and you can ask your questions from where you are. And I invite all the speakers to come to the podium so you can answer the questions. And we'll continue along with the medical forum at the same time. But all the current speakers, please come to the podium. Dr. Yegappan, neurologist, please come to the podium. I'm going to hand over the mic to Dr. Pillai. Dr. Pillai, I introduced herself, but she's the Vice President of NPNA. I'm glad to have her as my mentor and be here to arrange the symposium. Without her, this would not have been possible. Thank you.
Thank you. I just want to
20 years with medical.
and Dr. Yegappan is a neurologist, retired now, but he's got plenty of experience behind him from Canada. And he's not only just a mentor just for medical neurological problems, but he does a lot of devotional work behind Devaram, any questions, anything you want to ask about Nagaratas or about Hindu science, you can ask him also. So with that, we'll just open the floor for questions. Okay, the questions for the panelists you can ask first, and then any other questions. I can answer OBGYN questions, you can answer for cancer questions and so on. So any questions, feel free to ask.
One tidbit I just learned, Dr. Yegappan is my college senior from Kilpatrick Medical College, Chennai.
20 years before you. Okay, questions? Yeah.
Yeah, I got a question. I think this is for Dr. Srini, cardiologist. So whenever we go for this NMR lipoprofile test, it's pretty challenging to bring this LDL particle size. They're saying it's supposed to be below 1,000, sometimes it goes up to 1,500, 1,600. It's just a genetic, or is there anything you can do with the diet and exercise? Is it typical stuff to bring it down?
Yeah, you have a good question. It is very hard to increase particle size. It's easier to bring the LDL level with the statin medications, but exercise does help a little bit to increase particle size. But it's something that is genetic, and so somewhat you have, at this point of time, you have not a whole lot of options.
This is again for you, Dr. Srinivas. After COVID, a lot of people died due to sudden heart failure without any reason. They were just walking, dropped dead. Is there any proven results in the last 2-3 years? Is that related to either COVID or taking the COVID vaccine? Either one.
Yeah. We know that COVID does cause cardiac damage. I remember early on in the pandemic, I did a heart catheterization on a patient. We didn't have any fever or anything. It was just a heart attack situation. And turns out the coronary arteries were normal. And then we went back and checked the COVID test and it came back positive. Of course, all the cath lab personnel were already exposed to this patient by that time. And there is a lot of reports to say that COVID itself can cause cardiac damage. Now, as far as vaccine, there is a small increased risk for vaccine-related cardiac issues. And so there is risk to the vaccine. Initially, of course, the benefits of the vaccine outweigh the risks. Now, when you come to multiple, booster doses and stuff, then you have to be very careful in how many boosters you're going to go for, especially if you have family history of heart disease or already have a cardiac problem. Okay.
Thank you. So the boosters is preferred not to take. The risk is more taking the boosters rather than you fight with your own body mechanism, right? You had the initial shot.
I think because initially there was an increased risk of death. Once you have had the initial dose of the COVID vaccines, your chance of death comes down considerably. So then the benefit of the vaccine booster is lower. So then you have to reweigh the benefit to the risk, I think.
Thank you.
So a question from the medical forum here.
On that token, I just had a whole floor of people in my nursing home who got vaccinated around April, and the whole floor had a COVID 2 weeks ago. So the thing is that, but the thing is that virulence was very low, and I didn't have any hospital transfers or no deaths. These are all I'm talking about people who are 80s and 90s and things like that. So the virulence has gone down. It's more like a nuisance because it's, you have a positive COVID. What are you going to do? Yeah.
If the COVID made a damage with the heart, is there anything people can do, or it's irreversible?
Most of the time you see a small increase in what we call the troponin levels, which is an indication of muscle damage, but many times there's no change, visible change in the heart function. So I think it's not.
What about increased blood clots because of the vaccine? There's lots of talk about increased blood clots.
Actually, more than the vaccine, the COVID itself increases chance of blood clots.
And there is during COVID, there was a lot of incidents related to blood clots going to the lungs and then clots inside the brain. So brain damage is also common with COVID. So there is a small increase in hypercoagulability with the vaccine, but I don't think it's as much of a problem.
So what is the time frame to get this blood clot? Once you have the COVID, is it in a few months or can take years? They can still have blood clot?
I think it's only acute. Like it can.
Yeah, so COVID infection actually has caused a lot of problems. Heart attack is one of them. But long COVID, we hear a lot. It has several, the inflammatory disorder. It can be long-term fatigue. It can be long-term clot risk also, but mostly within the first 3 months is the highest period. We've even had patients with low platelets happening after COVID, and it's a viral infection. It triggers the immune system to fight the infection. But the immune system doesn't do what it's supposed to be doing. It starts attacking your own body. So nariya autoimmune conditions have happened after COVID infection, viral infection. So COVID is the bigger culprit, not the vaccine. But Sona Mari, the initial vaccines have been successful in developing immunity, and the COVID virus now is very less virulent, so to speak. It doesn't cause as much long-lasting problems as the original virus did. So hopefully it's a thing of the past, but COVID vandavangalukku, we still continue to see autoimmune disorders. So I have the mic, I'll pose a few questions.
Just on the same note, Dr. Yegapan can say just about stroke, increased incidence of stroke after COVID.
Yeah, during COVID, as pointed out, there is a blood clot formation. So we had actually one patient, McMaster, who came with stroke, a young fellow who had a COVID positive. It was during the endemic time. And we took him because for stroke, as you know, we take them to the cath lab and give injection, look at, because we can retract the clot. So we were doing it. Actually, my interventional radiology colleague was removing it. As he was removing it, new clots were forming. So it was during the acute period of COVID, we witnessed it. And there have been reports, a lot of reports at that time during acute period strokes due to that.
Yeah, and actually COVID treatment, we used anticoagulation, Lovenox and anticoagulant medications to help, because it was a bigger risk factor during the acute frame of COVID. Thankfully, we don't have that many hospitalizations, ICU admissions now. But when first COVID came about, all of that was a big picture and the stroke. So, moving on to a different topic, Dr. Lakshmanan, in the question, please explain number 2 and number 3 in GAD-7 anxiety scale.
So the GAD scale, number 2 and 3. So the most important symptoms in GAD, which is generalized anxiety disorder, is number 1, the patient has to feel anxious and nervous and on edge, right? That's one symptom. The second symptom should be worrying, excessive worrying, and worrying too much about different things, which means they worry about everything. It has to be there for most of the days for 6 months. Okay, they have to have these symptoms most of the days for 6 months. And the worrying should be out of proportion to what's going on in their life. So, for example, I was anxious about my speech this morning. That's all I was worried about, anxious about. But people with anxiety disorder, they're anxious about everything. They're anxious about, okay, for example, you come here, you worry about, what happened, I left my house, Is there going to be flooding or is there something? I have to go to grocery stores. How am I going to go? How am I going to drive? They worry about job, finances, health, children. They worry about everything which is excessive and out of proportion. And this goes on for 6 months, and then only then you can diagnose. The important thing, another thing is question number 2. Even though they know that, your wife may, your spouse may say, hey, you're worrying too much, எப்பவுமே யோசிச்சுட்டே இருக்கீங்க, anxious ஆறீங்க, tension ஆறீங்க. So the thing is, so you tell the person who is worrying, and that person, even though they know they are worrying, they cannot control it. So that's what number 1, 2, 3. For anxiety disorder, to diagnose anxiety disorder, they have to have these 3 symptoms plus 2 or 3 other symptoms like difficulty sleeping, poor appetite, concentration, they cannot concentrate and cannot relax. Another important symptom, irritability. That's why if your spouse is irritable all the time, then you need to give this question every time. No, really. No. Yeah. எதுக்கடுத்தாலும் வல்லுவல்னு சொல்லுறீங்க. Yeah, it's an important symptom. Yes. Yeah, sadness is more feeling down and depressed. Worrying is just, you're anxious about everything. What's going to happen? They always worry about the worst case scenario. Hey, right? There's chances are less, but they're too much worrying. Yeah, they cannot relax. They're afraid of something. They're always afraid of something bad going to happen. இதாயிருமா அதாயிருமா வீடு எழுஞ்சிருமா பிள்ளைகளுக்கு கிட்ஸுக்கு நடந்துருமா அவங்க தனியா போறாங்க வந்துருவாங்க.
How do you treat that?
Refer to
treat CBT, cognitive behavior therapy, and then medications. Yeah, medications really helps. Yeah, medications like I told you, right? SSRI, selective serotonin reuptake inhibitors like lexaprazole are most commonly prescribed. Among all these medications, we have about 10 medications for anxiety and depression, but these are the most commonly prescribed because they've been there for 30 years. They work well, less side effects, less expensive, good safety history. And but we see patients improving the first week, second week, slowly, and then by two months, they're completely better. I have patients who come and tell me, hey, I wish I had taken this years ago. So good, I'm feeling so good.
What happens after they stop taking medication?
Okay,
Are they hooked onto it for the rest of their life?
it's not hooked. No, please do. That's a main misconception. Hey, don't go take psychiatric medications. You're going to be on it forever. No, you can stop it after anytime. I tell my patients, you can stop it anytime. But the recommended period is 6 to 9 months because the course of the anxiety and depression, even if you don't treat, they'll last for 9 months, right? So you want to take this medication for 9 months because if you stop it after 3 to 4 months, the anxiety or depression will come back. So we say, take it for 9 months, a year. Then after that, if you want, you can wean off of it. And some patients, they don't want to wean off of it. I'm feeling so good. Everything is going good for me. My job is good. My wife is happy. I'm happy.
Yeah, one thing, primary care physicians can handle this in the initial stages. So உங்களுக்கு இந்த மாதிரி early symptoms or of people with early symptoms, all they have to do is bring it up to their primary care physician. They can evaluate and they are able to prescribe a lot of these medications. ஒரு லெவலுக்கு மேல போயிட்டா they will refer to a psychiatry physician. So there is no taboo in this. This is very common in the US, and please bring it up to your primary care physician if that is the case.
So 80% of these prescriptions are prescribed by family doctors, not us. 80% of antidepressant prescriptions by family doctors, and this is the third most commonly prescribed medications after cholesterol medicine, blood pressure medicine, and the stomach medicines. Millions and millions of people take it. 80% prescribed by PCPs. And if you guys want to, if a PCP cannot help you, if it's getting worse, you guys come and see us. And now with the telemedicine, you don't have to go to psychiatrist's office and you don't want to, you're afraid of parking there, you're afraid of sitting in the waiting room. Somebody's going to see me.
One follow-up question on that one. So you said you were anxious this morning when you came in. No, it's common. It's common. You can publicly speak, right? So in that scale, that to me seems like 0 to 4, right? It's miles for a specific event. So when do you really seek help? At what level you go and seek help?
Oh, that's a very good question. Very good. I forgot. I think I told you. I forgot. Okay, any psychiatric disorder, right? Anxiety, depression, obsessive compulsive disorder, ADHD, any disorder, very, very important. You seek help or you'll be diagnosed only if it affects your daily life. Okay. If it is hard for you to work and function on your job, I don't want to go, I cannot concentrate. I don't feel like getting out of bed. Okay, number one, hard to do your job. Number one. Number two, taking care of things around the house. Washing dishes, doing things, putting the kids to sleep, taking care of things at home, looking at finances, bank. Third thing, getting along with other people, relationships with your coworkers or your family, children, spouse. So these three very important. Unless your symptoms affect these three areas in your life, you will not be diagnosed. You will not, you don't need treatment.
The function or not is the most important thing in determining the treatment, whether you're able to function or not. That's true. நீங்க கேட்ட ஒரு specific question yes, there is a condition, the social anxiety, stage anxiety, performance anxiety. There is very, very specifically to somebody's going to give a talk or something like that. They have medications are there. They will just take it as needed basis. Like we give propranolol sometimes for for getting anxious. Just they're going to have a talk and they're getting anxious. The medications are there. Yeah, many stage performers they use that.
Yeah, that's also is a disorder. We have a lot of disorders. So social anxiety disorder is the one it is a psychiatric DSM for, we have diagnostic statistic manual. I didn't understand your question, sorry. Social anxiety disorder is common. I treat social anxiety disorders like Dr. Arun said, propranolol. Yeah, there is a medication, you can take it as needed before you go to give a speech or if you give a performance or anything. So what it does is it helps you with the physical symptoms of anxiety, like hand tremor, shaking, heart palpitations. Dr. Srinivas knows about this medication. Heart palpitations and even sweating. So you take it about 1 hour, 2 hours before you go and give a speech or presentation for kids and students in classrooms. But that's only helps at that time. But social anxiety disorder is always there every day, right? For months and months a year. For that, you have to take these SSRIs every day, like lexaprazole every day. And it does help. I have patients, several patients who got better.
Yeah, my daughter took it for the step 1 exam.
So,
one question. How long you can continue the SSRI? Because as you said, people, they have recurrence once you stop it. For people who are anxious all the time and everything, can you continue lifelong for several years? Or how
yes. 20 to 30% of patients or even more, they have recurrent depression, anxiety all the time, again and again. I have patients who are taking medications to roll out maximum dose for 30 years every day. So you can take it any number of years, every day. Good safety record.
Do we have a natural cycle to break? You said after 9 months, it naturally breaks or it's not?
One episode, okay, naturally breaks for depression after 9 months, 10 months, naturally breaks, but you can have recurrence. So that's why one of the things is to prevent recurrences, you go to counseling, therapy, very important, because the benefits of therapy continues for a long time because you're changing your way of your coping skills. But medications will help only as long as you take it. So that's why counseling is important. Yeah.
Regarding the functional limitations, not only in psychiatric problems, but also in memory issues. See, நம்ம எல்லாருக்குமே கொஞ்சம் மறதியா இருக்கும் எல்லாருக்கும் அது dementia வந்துடுச்சான்னு we all think about it. But unless it limits your daily activities, you don't need to worry about the memory issues. Same thing like psychiatric problem. So functional limitations இருக்கணும். ரெண்டாவது behavior problems. Behavior அவங்க இந்த மாதிரி இல்ல ரொம்ப அஜிடேட்டடா இருக்காங்க இல்ல ரொம்ப டிப்ரெஸ்டா இருக்காங்க எப்போ ஒண்ணும் பேசாம இருக்காங்க அந்த மாதிரி இருந்தா தான் then the dementia becomes more obvious and needs medications. But if you have short-term memory, just மறந்து போறது அதுக்கு ஒண்ணும் பயம். Another question I want to ask, if you are taking medications for anxiety and all, and you stop, will there be a very big rebound phenomenon?
No rebound, only thing is you have to wean off of it. Okay, very important to wean off of it gradually. Otherwise, you have withdrawal symptoms like dizziness and nausea, and you have electric shock-like sensation in your brain. It's called brain zaps. So you have to gradually wean off of it. Rebound means the anxieties, the recurrent disorders. If you don't take medication, you're fine for a year. It may come back.
So அவங்க சொன்ன மாதிரி வந்து உங்களுக்கு அக்யூட் காரணத்தால வருது இப்ப லாஸ் ஆஃப் சம்படி அந்த மாதிரி அக்யூட் காரணத்தால டிப்ரெஷன் அந்த மாதிரி வந்ததுன்னா ஷார்ட் டேர்ம் உங்களுக்கு அந்த மெடிகேஷன்ஸ் will get you over the hump and then you'll be fine and you wean off the medication and you won't need it again. இல்ல உங்களுக்கு இது chronic ப்ராப்ளமா இருந்துச்சுன்னா அவங்க சொல்ற மாதிரி on top of medication you do the behavioral therapy. It changes your outlook, changes how you are going to react to situations. So then you're able to wean off the medication. And for people who are not able to wean off after all of this, they can be on long term. There's no harm in being on it long term.
And to add to that is, Anna probably alluded to it, you need to take the medicine at least for 2 weeks to see the effect starting first. And when you would stop, you have to slowly wean. You cannot just cold turkey, you cannot stop. Okay, I'm feeling good. Then it will come back, right? Right, Anna?
Yeah, I think, yeah.
And since Mutharu set this up, could you also describe about acute or prolonged grief periods?
So usually grief, somebody you lose your family, a member, or somebody dies close to you. Usually the grief period lasts 6 months. Right? So 6 months you don't need any medications. Family support, talking to people, counseling. You don't need counseling. Just talking to your friends and family. And then if you're still there, go for counseling. And after 6 months, if you start continue to have depression symptoms, then it's time to treat, especially if the patient is talking about hopelessness. Hey, I want to go and join my, my spouse or husband or wife or dad. I want to be with him. If they start talking like that, I don't feel like living, I want to be there with him, Then, you need to quick go and give medications. Right?
So there are a lot of questions for Dr. Srinivasan. So let me ask those questions. Why sudden cardiac death is more common during sleep?
Sudden, there is, it has to do with what we call the autonomic nervous system. Even when we are asleep, most of what we call there are two kinds of nervous system where we are able to control ourselves. We think of moving our hand, we can move our hand. We think of doing something with our legs, we can do it. But there is a nervous system behind us that controls the heart, the way the lung moves, and it's to do with increased sympathetic activity while you are asleep. And that nerves are working on the heart all the time, and changes in their activity can lead to changes in the heart, the risk for heart rhythm problems.
Is there something you can do to help that or prevent such an occurrence? Like, is it exercise or is it what helps prevent? That is not under our control, yeah. So is there anything you can do prophylactically or preventively to avoid that?
Not that I know of.
Okay. So இன்னொரு question அவங்களுக்கு கேட்டிருக்காங்க. In heart rate response calculation, how did they come up with the number 220?
That's just algorithmic. They looked at math. When they did research on how to do exercise testing and stuff, They looked at people, how much they can run, what is the maximum heart rate they achieve. And then just like any prediction graphs, you look at people, observed values between people's age and what the maximum heart rate they achieve. And they come up with a formula that 220 minus age most often predicts the maximum heart rate achieved.
What a question, and why are cardiologists reluctant to prescribe a calcium index test?
Calcium?
Calcium index test, I think, for like calcium
scoring. There means ACC has guidelines on using testing. It's not reluctance. There is a set of recommendations. And a certain group of patients who are at high risk will benefit from calcium testing as a prediction of risk.
But isn't it a good, way to predict upfront, knowing if you have a blockage coming up versus discovering it after the fact?
It comes to the question of screening tests and their usefulness. No test is 100% perfect in life. So there is always this false positive and false negative. And so testing can sometimes lead to more unnecessary testing. So you have to always weigh in those aspects. The calcium scoring is fairly sensitive, but you are looking for blockages that are 70% or more if when you come to fixing mechanically. That's when there is actually an effect on blood flow to the heart. But minor blockages are important in terms of doing lifestyle changes and prevention methods. But that's something that everybody should aspire to do, I think.
Is there any benefit with fish oil capsules and vitamin E?
Fish oil capsules, you have to take a lot of fish oil to actually be beneficial. There is medication called Lovaza that came out. You have to take 6 of these fish oil capsules per day. And to get compliance from patients to do it is hard. So yes, fish oil will be helpful, but to take it on a regular basis, if you can take a lot of it on a regular basis will be helpful. Of course, there is another medication that came out that is a specific kind of omega-3 fatty acid, but it got FDA approval as a prescription medication, but there is so much legal wrangling behind it. Right now, it's not commonly prescribed yet.
Is there a connection between cholesterol medication and diabetes? Why does HbA1c go up with statin medications? How do you avoid this?
The one thing that I want to tell about statin medications is this, that statin medications increase life expectancy. The funny thing is that I always tell my patients, there's so many medications out there in the market. If you want to reduce headache, there's one thing. If you want to stop this, there's another thing. But if you look at medications that have been scientifically shown to increase life expectancy, you can count them out with your fingers. And statin medication is one of them, because for a person to show that it increases life expectancy, you have to give it to a few thousand people, and you have to count out who is dying when. And so it takes a lot of resources to conduct these kind of studies. So they're conducted only when there is a good chance of getting a positive result. And if you look at statin medications, there is studies not only in the US, studies conducted in multiple geographical areas, in multiple sets of patients, patients who have had coronary artery disease, just patients who have just high cholesterol, no heart disease. So that's called primary prevention. Even primary prevention studies show that if you have a high cholesterol, you take a statin medication, you will not just have low cholesterol, you will just simply live longer. So statin medications have very strong clinical indication. And so you would have seen when these early studies on statin medications came out, almost 100% of doctors were taking statin medications. So, and there is always this concern that statins can cause some dementia or brain damage. And there are all these studies that have some questions on the efficacy or safety of statin medications. But if you look at the overall use of statin medications given to millions of people over a period of time, I think you, when you're taking a statin medications, don't worry too much about possible effects. It's possible that statins increase the hemoglobin A1C mildly, but overall risk to benefit ratio is clearly in favor of usage of statin medication.
Dr. Srinivasan சொல்ற மாதிரி primary prevention பண்றப்போ you can take the lowest dose and get away with it. When you wait for the heart attack to happen and then use, the cardiologist will push the statin to the maximum dose. So you're better off doing prevention rather than having to deal with it after.
The statins not only reduce cholesterol, the effect of it, what's called pleiotropic effect. It smoothens out the cholesterol formation in the blood vessels. That's the reason why it is helpful. Even though your cholesterol is normal, your doctor prescribes for heart attack or stroke, they prescribe a high doses. That's because of smoothing out the plaques in the neck or in the heart, anywhere else in the blood vessels. It just smoothens. Because when it is not smoothened out, it can break up and can go and block an artery and cause stroke.
So, Dr. Yegapani, உங்களுக்கு the question வந்து என்ன கேட்டிருக்காங்க, new brain fever in India, Kerala. Any insights?
I don't know about it, but in Kerala, there has been sort of viral infections, peculiar viral infections like in fowls, like hen and all those things. Birds flu was there. And usually, traditionally, there is a forest fever used to be what's called, used to be common in Karnataka, but also noted in Kerala. It's a viral infection, can cause hemorrhage in the brain, and it can cause worsening of memory and all those things, behavior problems. But I don't know about the recent one. I'm not sure which virus has caused it.
Okay. Dr. Arun, when at what age do you need to start planning for Medicare?
I think if you're going to be reaching 65, I think probably in the past, anyhow, you're going to usually people make a decision in that initial enrollment period, which is at 7 months. So you might probably want to make some discussions during that period of time. Or a few months before it. I think that's probably enough, because these plans, they're not changing every day. So I think if you make some decision, usually I think that should be okay.
So Dr. Srinivasan, coming back to you, is aspirin 81 milligram per day really helpful in preventing heart attacks?
Yes, the simple answer is yes. Aspirin 81 milligrams is helpful in preventing heart attacks. But recently, about 1 or 2 years ago, there was national news on primary prevention. Before, there was a significant encouragement of aspirin use in everybody who was over 40 years of age. But however, they came up with new analysis to suggest that the main problem with the aspirin use is gastritis, and can at times cause stomach bleeds. So the analysis suggested that the risks associated with aspirin use were not overcome by the benefits. So so they stopped recommending aspirin blanket use on everybody who's over 40 years old. But I would say that you should individualize your own decision. If you have a strong family history of heart disease or your cholesterol is always high, I think your specific individual risk may be higher, and in which case you should make a individual decision discussing with your doctor.
Are taking 3 types of medicine for hypertension too much?
Yeah, add to that, on the baby aspirin, they did a big study in England, and they said the 81 milligrams was not the appropriate dosage and really doesn't do anything. Or they, for prevention, like you said, well, okay, there's a family history of heart disease, and you have no proven factor like elevated LDL or whatever. Then they said it has to be even 60 milligrams is sufficient, is one. And the other thing is, if you really need a higher dosage, then you need to do that. And we have better anticoagulants now rather than the aspirin.
Yeah, that is called the physician in UK. That was the physician survey study. They did this in primary physicians. They were given 81 milligram of aspirin and they found no benefit. But one thing is, I'm sure Dr. Srinivasan will agree with me. There was a gender difference, right? In female, it was more protective than males for preventing heart in that 81 milligram. But we also do not advise from a stroke perspective for primary prevention, no aspirin. Only when you have a problem, then aspirin, because as he said, the benefit is not overcome by the side effect. Side effect is worse. 1 to 2%, you can even have cerebral bleed from aspirin, even 81 milligram.
There are people who have established coronary artery disease and taking it twice a day is better than once a day.
I'm not sure that is true. I don't know whether there's any specific. The funny thing of aspirin is that it's called a hit and run drug. What it is this, unlike for pain relief, the aspirin used for what we are using it is for antiplatelets. So once an aspirin knocks off a platelet, it's knocked off forever. The way the effect is overcome when you stop aspirin is that new platelets are constantly formed by the blood in the bone marrow. And so when new platelets come, they will replace the old ones. So I know when aspirin was initially introduced, you can expect aspirin effect to last 5 to 7 days even. So I don't know that doing it 2 times versus 1 will make a huge difference. As far as the question about the blood pressure medicine, I have several patients. I have 1 or 2 patients who are taking 5 blood pressure medicines and still not able to control their blood pressure. The recommendation is to try to get to the right numbers, independent of how many. What I tell the patients is this: like if you have a water problem in your house or someplace, you stop the water in one location. The water will find a different way to get to the same location. Somehow leak and get there. Blood pressure is such an important component of our body mechanism controls that there are so many systems in our body to try to maintain the blood pressure at what the body thinks it needs to be maintained. So we attack one aspect of the blood pressure. We use a medication like beta blocker. We act on one system of the blood pressure. We think we have stopped it. It works for 1 or 2 days, and the body finds a different mechanism to go and increase that blood pressure. So sometimes you have to use a little bit of a medicine that acts in multiple different ways to achieve that control. So the nature of blood pressure problems many times is that you end up needing a few medicines to try and get it under control. At one time in 1950s, they used to do surgeries, 50s and 60s. If you look at books, they would go and cut the sympathetic nerves and stuff to control blood pressure when we didn't have good medications for it. But now you can't find a surgeon who will do that surgery.
We are getting close to wrap up time. It's 11:45. So I'm going to finish with a few questions to the panelists. Dr. Arun, there are a few questions. Inga, what does Medicare cover and how much does it cost? How do I choose the best Medicare plan? And how many people plan to use private Medicare Advantage plans, and how many plan to stay with regular Medicare and purchase a supplemental plan? How many know the difference between the two ways to cover healthcare after retirement? Presentation. So whoever asked the question, please watch the presentation.
So that's right.
But just if you want to say, what is your take on what your suggestion would be?
My suggestion would be that if you're not sure about what plan to take, take the A and B. As I mentioned in my talk, do the build on pathway. Take the A, take the B, take the D, and take a supplemental plan for now. And then as you go by, depending upon whether you like it, you'll stay with it. And if you don't need, then you can probably continue to stay with that. And then at some point of the time, depending upon your need, if you think this is too much, probably change to a lower cost advantage plan. But the problem is that as you go by, your disease might be more, and there are chances that you might probably need more medications or need more services. At which time probably as you go by, you might probably change the plans later on.
So another question is $1,600 to be paid by the patient to the hospital if they have inpatient over for 1 day. Is it for every inpatient admission?
No, there's a 60-day period in that. The first initial 60-day period, the deductible is $1,600. That will be prorated usually. That's how Medicare usually will do it. So that $1,600, like for example, if you're there only for 3-4 days for that 60-day period, if you're admitted, so that deductible will be covered for that. And then you did not get readmitted during that 60-day period again. And then, like for example, January 1st, you were admitted to the hospital, and then you did not have any other admissions until the 60 days, which is basically March 1st or 2nd. Then the second period will start. So for each 60-day period, it's $1,600 deductible.
Okay.
If that's clear. Yeah.
Yeah, I'm not sure I'm able to read this correctly. If there is premium in Advantage plan up to IRMA. The
income related monthly adjustment.
Yes.
But you did mention that there is a premium for Medicare Advantage. My understanding, there is no premium for Medicare Advantage. But if it is, then is it tied up to the earmark?
No, but you still have to pay your Medicare B premium to take it, and the earmark surcharge will apply. So the place where you are might have a different copay from the same person with the same age, same disease in a different geographical area. So that'll apply.
So question, Dr. Lakshmanan, what causes psychiatric illness? Is it a chemical imbalance or a hormonal imbalance or attitude? How to reduce stress other than the 6 pillars of health?
Yeah, I think the main reason to people have psychiatric illness is mainly genetic, right? Biological genetic. So if you have a genetic family history, somebody in your family has depression, anxiety, whatever it is, you are more prone. Like I said, 60 to 70% the illness are inherited, right? So the cause of the psychiatric illness is a biopsychosocial model. Unlike other medical illnesses, ours is biological, genetic, psychological, like I said, in personality, how you were raised, what kind of personality you have, and then social, how you deal with the daily stress. So all of this is important, but you have to have the genetic vulnerability. If somebody in your family has, and you carry the genes, then you still may not have anxiety, depression, unless you are put in a stressful situation. And then it can, so You combination of all of those: personality, genetic, and environmental, social stress. And how to reduce the stress? So stress, you need to listen to your body. So if what is stress? Stress is your body's natural response to a difficult situation. So if you work 8 hours a day, 5 days a week, maybe you're okay. But if you work 10 hours a day, 7 days a week, then your adrenaline, noradrenaline, and cortisol produced constantly for a long time, then you will feel symptoms in your body: headaches, stomach ache, body tension, muscle tension, increased heart rate, chest tightness. So you listen to your body. If you have stress, then you need to do things like yoga, meditation, support from family, exercise. These are all things you can cut down the stress and cut down your work stress, whatever is causing the stress. So if you're in a job, constant stress, you cannot get along with the boss, then you need to see a counselor and think about moving to another job or doing something else. Because whatever medications you take, whatever counseling you get, unless you situation is changed, is going to be there.
Okay, last few questions. Any link between dental treatments and heart attacks?
The main link between dental treatment and problems and heart issue is mainly infection. Whenever you have dental cleaning and stuff, you do have some bugs that get into the bloodstream. And if you have certain heart conditions, then you have a little higher risk of them seeding in the heart and causing infection in the heart. But as far as I know, there's not a huge link between.
Any comments on recent literature on widespread use of metformin beyond diabetes?
Yeah, actually, metformin is being commonly used for a condition called polycystic ovary syndrome, PCOS, and it helps to, one, it brings down the weight, and therefore the conversion of all the excessive androgen to estrogen. There's high androgen levels, then it gets converted to high estrogen levels, and that can cause them to have irregular menstruation, weight gain, difficulty getting pregnant, and so on. So they are given for patients who have established diagnosis of PCOS when they have irregular cycles and oligomenorrhea, as we call them, and if they have any difficulty. Right? And the other thing I wanted to comment about what Dr. Lakshmanan said, the hormones have a place to play in anxiety, depression, as well as this thing. And it's very commonly we see PMS, it's called as premenstrual syndrome. Now it's called premenstrual dysphoric disorder, when it is really affecting their performance kind of thing. They cannot go to work. They're so tired, they're fatigued, and then and as soon as they start the menstruation, which during the cycle, the estrogen levels start being produced by the new developing follicle. So once the estrogen comes in, then they are happy. So there's no problem. The same thing happens immediately after delivery. And when there's a high level of estrogen progesterone, it comes down dramatically to very low levels. So patients become very depressed. And so postpartum depression can be very harmful. They can have suicidal, homicidal tendencies too. So that's the time that you don't want to treat them with the hormone at that time, but a lot of counseling and antidepressants at that time for a brief period, like Dr. Lakshmanan said. It doesn't have to be forever, for 9 months or anything, 2-3 months, and then they get over it. And then we have to look out for the same problem to happen the subsequent pregnancy too. Menopause is another situation. Postmenopausal status, again, lack of hormones, lack of estrogen. And when we replace them with even very small amounts, patients start feeling very well, very quickly.
Yeah, like statin, metformin also prolongs the life. There's been studies showing that metformin increases the lifespan. So people, when they're taking for diabetes, they found this as an incidental finding. Regarding the dental one, I wanted to say is people who are on aspirin for heart or stroke, if you are going for dental, please do not stop it. I have seen patients after stopping aspirin develop stroke when they went for dental and coming back with stroke. You can tell the dentist nothing will happen with the aspirin, bleeding can be stopped. So please do not stop the aspirin.
I would say. I know both Dr. Srinivas and Dr. Jayapur touched about diabetes and metformin, and this has already been in clinical practice. it's also indicated in pre-diabetic condition itself. And not just diabetes, even if your A1C is 5.7, 5.8, or 6, if you're not even a diabetic, if you're pre-diabetic, the new indications are there. It's been there for a few years now. We are giving metformin even for pre-diabetic.
Yeah, the obesity can help on metformin, and it is also an anti-inflammatory and helps bring inflammation levels down in the body. So if there is a reason to treat down pre-diabetes, same thing holds good for statin, even early cholesterol. We are better off doing it than not doing it. So thank you, everyone. I think we have to wrap up at this time. Thank you for the audience for excellent questions. Thank you to Venkat and Ganesh for being there and supporting us through this program. Without both of you, this would not have been easy for us. And thank you to all the speakers and the forum panelists for being here and sharing your knowledge with the audience. Thank you, everyone.
Our main thanks, Prime was not here earlier. I thank NSNA and you especially for orchestrating this and then starting the interest, and then we were excited that we got the opportunity to work. Thanks to the speakers, excellent speakers. Thanks, Dr. Srinivasan, Dr. Lakshman, and Dr. Arun. Very nice talks. Yeah, thank you.
Thank you.
This will be available in YouTube, NPNA channel TV Live. The people can go and watch, and that will be available. And feel free to reach out to the doctors with your questions.
Yeah, one other thing I wanted to tell you is, those who are doctors, please join and become members of NPNA. Who are not doctors can definitely join NHC. It's called Nagartha Health Club. There is no fee for it, and for the membership for the physicians too. The residents, fellows, they do not have any fees.
True.
Okay, so students or medical students, premium students, please stand. Okay, and we'll be happy to see all of you in the future. And thank you both for helping us.
Thank you. Physiology.